Thank you once again. Welcome to the Department of Urology, Savai Mansingh Medical College, Jaipur. Today we have a teaching class on a very interesting topic, nanotechnologies in non-oncological urological topics. So this would be presented by Dr. Navdeep Garg and moderated by Dr. R.D. Sahu. And we are really fortunate to have today with us our guest faculty as Dr. Mahendra Bhandari. So I would request Dr. R.D. And Dr. Navdeep to kindly share your presentation and go ahead. Yes.
Good morning to all of you. Today I good morning to all of you. I'll be giving the presentation on the nanotechnology in the non-urological diseases. Myself, Dr. Navdeep Garg, moderated by Dr. R.D. Sahu, sir. This will be covered under following heading: Introduction, Role in the Specific Diseases, the Recent Updates, and the Conclusion. Coming to the introduction, nanotechnology is understanding and control of matter and processes at the nanoscale dimension, which enables novel applications in our field of urology. Coming to the definition, nanoparticles have sizes falling between 1 to 100 nanogram in at least one dimension and are referred to as nanocarriers when used as a transport vehicles for another substance. There are several other types of nanocarriers with different compositions like organic, inorganic, or maybe both, and the structures that give them the unique physico-chemical properties and the cargo capabilities. In our field of urology, most of the research involving the use and development of the novel nano-based drug delivery platforms has focused mainly on the cancer treatment, but the potential application of the nanotechnology in non-oncological urogenital research and therapeutics is also very immense. The current management of erectile dysfunction and the urinary bladder diseases relies mainly on the oral medications that are very not effective for all patients and can be accompanied by the systemic side effects that reduce the patient's adherence to the treatment. However, because these urogenital organs are easily accessible, they are highly amenable to topical delivery of therapeutics, like directly to the penile dermis or into the bladder by the transurethral cannulation. These alternative routes have been explored, and intracycle therapies are used to manage some bladder conditions. However, delivery of therapeutic through these routes is also limited by natural obstacles, which includes the remarkable barrier properties of the skin and the urothelium that make hard the penetration and absorption of the dermally applied therapeutics and dilution in the urine and washout with micturition of the intracycle administered therapeutics. These natural barriers can overcome using these nanocarrier-based delivery systems. The use of the nanotechnology is basically in the well described and reviewed in the literature, like in urological cancers of kidney, prostate, as well as the bladder. In comparison, its use in research, diagnosis, and treatment of the benign urological conditions, which affects a larger proportion of the population, has been limited. So here we'll be discussing about the erectile dysfunction, overactive bladder, interstitial cystitis, and the catheter-associated urinary tract infections, where nanotechnologies are used. The commonly used nanocarriers are liposomes, micelles, nanoparticles, carbon nanotubes, carbon dots, dendrimers, and nanogels. This is basically the diagram showing the nanocarrier-based delivery system for a targeted drug therapy. Coming to the role in the specific disease like the erectile dysfunction, as we all know, the current therapeutics are PDE5 inhibitors and the intracorporeal injections. The challenges where we find the PDE5 inhibitors can cause off-target effects like headache, nasal congestion, as well as the dyspepsia. The patients with dysphagia have difficulty swallowing oral medications, and the absorption pharmacokinetics of the oral PDE5 inhibitors may be affected by the eating and the diet. The intracorporeal injection, as we all know, can cause pain at the injection site, pain during erection, as well as the hematomas formation. So here, the nanotechnology-driven therapeutics can be used are topical nitrous oxide nanoparticles, topical tadalafil, topical PGE1 ethyl ester nanoparticles, papaverine nanoparticles, topical opioorphin nanoparticles, nerve growth factor, HA nanoparticles, DHA nanoemulsions, as well as the Bio 300 nanotechnology nanoparticles can be used. So what are the basically advantages of using this in erectile dysfunction is that it allows the local as well as the topical delivery of the therapeutics, avoiding the effects of eating and the diet on the absorption, pharmacokinetics, and it also avoids the first pass metabolism, and it is very less invasive. The various topical nitrous releasing nanoparticles use have led to the local and the topical delivery of the nitrous oxide, which is impossible without nanotechnology, as it induces the erectile response without affecting the systemic blood pressure. Other topical PGE1 as well as the papaverine nanoparticles are also used, which modulate the smooth muscle relaxation in erectile dysfunction. Nerve growth factor as well as the DHA nanoemulsion also promotes the nerve regeneration following radical prostatectomy, and the Bio 300 also prevents the radiation-induced erectile dysfunction following prostatic cancer radiation therapy without sacrificing the tumor radiosensitivity. Now the challenges here in erectile dysfunction, if we use the nanotechnology driven therapeutics, is that the clinical translation from the animal models to the humans have not shown the significant result and are very limited. Approval would need to consider both the bulk pharmacological agents as well as the potential novel physiochemical properties associated with their use, as well as at the nanoscale. And some nanoparticles like PGE1 ethyl ester, if we are using, has not been established, treatment has not been established. Whereas the papaverine nanoparticles shows the low bioavailability, and if we are using the opioorphin nanoparticles in ED, it can also lead to the priapism. Coming to the second, the overactive bladder. Here we all know the currently therapeutics are used are the oral anticholinergics, intravesical antimuscarinics, as well as the intravesical botulinum neurotoxin A. The challenges where here in the current therapeutics are that it can cause oral anticholinergics can cause dry mouth, constipation. If we are using the intravesical antimuscarinics, it can cause low retention in the bladder, and intravesical botany may requires re-injections, high rates of where we can see higher rates of urinary retention, UTIs, hematuria, as well as the pain at the injection site. Here, the nanotechnology-driven therapeutics can be used are lipobotulinum, lipopolysomes, encapsulated capsaicin, lipopolysomes, encapsulated oligonucleotides, nitrous oxide nanoparticles, as well as the mirabegron PEG nanoparticles can be used in overactive bladder. Now, the advantages here are it can potentially allow local intravesical delivery of the anticholinergics to the bladder, reducing the systemic side effects and increasing the treatment compliance. Whereas the nanoparticle delivery systems can be engineered to increase the indwelling time of the intravesical and administered therapeutics. Lipobotulinum reduces the urinary frequency and urgency without increasing the risk of the urinary retention as well as the UTI. Coming to the next disease, interstitial cystitis, the current therapeutics, as we all know, have a behavioral modifications, anti-allergic and anti-inflammatory drugs, pain modulators, anticholinergics, botulinum toxin, and oral medications. The current therapeutics challenges where we felt are there is no single therapeutic agent, and the patients often require multimodal therapy. Oral medications, if we are using, can cause nausea, constipation, dry mouth, weight gain, diarrhea, vomiting, and lightheadedness. There is unclear optimal dose and frequency of dosing for intravesical drug instillation, which can cause pain upon instillation. So here, nanotechnology-driven therapeutics can be used are empty liposomes, botulinum toxin, and lipotacrolimus. The advantages of using this in nanotechnology therapeutics here are intravesical administration of the empty liposomes can protect and repair the urothelial layer and improve pain, urgency, and overall symptoms without treatment-related adverse events. Whereas the lipobotulinum, if we are using, improves the suburothelial hemorrhage, recovering urothelial tight cell junctions and adhesion proteins, which decrease the substance P release and inhibits the overexpression of the inflammatory markers. Whereas lipotacrolimus, if we are using, it increases the tacrolimus indwelling time and reduces the drug systemic exposure. Now the challenges here are the same. Clinical trials have not been reached properly, and if we are using the lipobotulinum toxin in clinical trials, there was no difference in the outcomes between the treatment as well as the control group. Now the role in the catheter associated UTIs. Currently, as we all know, there is to reduce the COTI, we can have reduced use and duration of the urinary catheters, and urinary catheters coated with silver ions can also be used. The challenges here are the patients with chronic urinary retention cannot reduce the use and the duration of the catheterization. Catheter coated with silver ions shows mixed results in terms of efficacy and are not cost effective when compared to the normal standard catheters. The nanotechnology here in COTI can be used as catheters coated with silver, copper, zinc doped copper oxide as nanoparticles, as well as the nitrous oxide nanoparticles. The advantages here are the catheters coated with silver or zinc doped copper oxide nanoparticles inhibit the biofilm formation. The catheters, if coated with copper nanoparticles, decrease the antimicrobial activity by crossing the bacterial cell membranes and damaging the bacterial enzymes. And if we are using the nitrous oxide nanoparticles, it can prevent adhesions and biofilm formation. The challenges are the clinical translation from the animal models to the humans has been limited, and the translation of nanoparticles to the preclinical animal models are also been limited here. Now the role in specific area like the prostatic specific antigen screening post radical prostatectomy, a gold nanoparticle based barcode assay has been described in literature, which shows helps in the detection of the PSA recurrence after the radical prostatectomy. It has shown 300 times more sensitivity than the conventional assays and may help in detection of the undetectable PSA levels after the radical prostatectomy. The microcantilevers that bend with the deposition of the PSA on the surface have been reported in the optimal assay of the ultra low concentrations of PSA. The gold nanoparticles labeled with antibodies can detect PSA levels as low as 1 picogram per ml due to the intense surface enhanced Raman scattering. Now the role in the bladder reconstruction, the traditional methods of bladder replacement use of a segment of intestine to replace the bladder, which has its attendant metabolic as well as the functional complications and the reduced quality of life. Moreover, they may be unavailable and donor site healing may be problematic. The impermeable nature of the bladder mucosa to a high concentration of the urinary solutes, toxins, as well as bacteria also cannot be replicated. It is to this extent that the nanotechnology has been also used to reconstruct the bladder. A three-dimensional porous polylactide glycolide and polyetherurethane scaffolds have been used as a framework for the growth of the bladder mucosa muscle, smooth muscle. These scaffolds have a nano-rough surface topography, which enhance the protein absorption, cell adhesions, growth, and the protein production. It is natural as well as the combination of natural and synthetic polymers which create these scaffolds. And a study in vivo animal study in partial cystoplasty model showed early regeneration of the urothelium as well as the smooth muscle at 5 weeks and similar tensile strength to the ileum. Now the role in the tissue sealant technology as well as in the robot surgery. In laparoscopic and the robotic surgery, hemostasis is achieved through the diathermy that cause the collateral damage and with charring and smoke production. Here, the NCL-TM system was introduced that uses the millions of nanoparticles embedded in a bipolar temperature coefficient matrix. The sealing is achieved at temperatures below 100 degrees centigrade as the nanoparticles interrupt the current flow above these temperatures, and it can reduce the maximum mean temperature to the 86.9 Fahrenheit and collateral spread to 1.1 millimeter. The reduced collateral spread may protect the cavernosal nerve, urethral, and the sphincter damage. It can also be used to achieve hemostasis of the dorsal venous complex in robot-assisted laparoscopic prostatectomy as well as in the laparoscopic nephrectomy. Now the role in the biodegradable stunt technology, a polyepsilon caprolactone as well as the polylactide glycolide ureteric stunt with nanofibers and micropores have been studied in the porcine model, which showed a gradual degradation in 10 weeks from distal to proximal fashion. When compared with the commercial polyurethane stunt, there was reduced polyuria as well as the ureteric vesicle inflammation with the nanostructured stunt. Now, the role in the artificial kidney, as we all know, it is an epidemic that has assumed global proportions, and it has been seen that a majority of the CKD patients are on hemodialysis, which has increased long-term morbidity. Here, a portable artificial kidney in the name of human nephron filter has been used, which can be worn by the user. It consists of two membranes with a cartilage. With a cartridge of two cartridges. The first G membrane produces an ultrafiltrate containing a low molecular weight solutes approaching the weight of the albumin, and which mimics the function of the glomerulus. The second T membrane performs the function of renal tubules and reabsorbs select solutes to maintain the hemostasis. The HNF is a product of molecular engineering which does not require a diacylate, which is very important. It can provide a GFR of 30 ml per minute and gives the patient mobility as well as the improved quality of life. Now, the role in the gene transfer and the detection of the single nucleotide polymorphisms. Viral as well as the non-viral vectors have been shown to transfer segments of genes from one cell to another. Viral vectors have a drawback such as insertional mutagenesis, immunogenicity, lack of specificity, and the limiting carrying capacity. It has been demonstrated that the herpes simplex virus thymidine kinase delivery by the folate-linked liposomes can inhibit tumor growth in prostate cancer. Similarly, interleukin-2 was delivered using liposomes for the immunotherapy of mouse bladder cancer. The nanoparticles have been engineered to deliver differing amounts of DNA to various types of tissues, which have a potential in treatment of various congenital as well as the malignant disorders. It can be used to diagnose a single nucleotide polymorphisms, like in PKD. It can also detect PKD1 as well as PKD2 single nucleotide polymorphisms by using these shell nanoparticles. Which can help in the early and inexpensive detection of the polycystic kidney disease and timely therapy. Coming to the conclusion, the nanotechnology has changed the face of molecular diagnosis and therapeutics in urology. While some advances such as nanoscaffolds for tissue regeneration are early in their development, others such as superparamagnetic iron oxide based imaging, liposomes, and gold nanoparticle based drug delivery system have reached the clinical trials with promising early results in diagnosis as well as the treatment of genitourinary malignancies. The development of highly sensitive assays improved by the means of gene transfer as well as the genetic diagnosis can help in timely diagnosis and treatment of the various genetic and acquired disorders. In spite of its exciting prospects, nanotechnology is not without its risks, as a nanoparticles which is being able to pass through the cell membranes are potential biohazard, and the research on their toxicity is very limited. The analogy is similar to that of the nuclear power, which is a both limitless source of energy as well as a tremendously destructive force. Stringent attention to patient safeties and needs, regulations to prevent misuse and inappropriate timely translation to clinical research hold the promise to change the face of healthcare in urology and bring the rewards to the truly beneficiary of the medical achievement. These are the references. This was a paper published in the Therapeutic Advances in Urology in 2022. And this is another paper published in Indian Journal of Urology in the name of Nanotechnology in Urology. Thank you.
Thank you, Navdeep. I welcome once again to all my residents and faculty and all those who might have joined us today on Zoom and YouTube. So thank you for joining us in our teaching class today. We all know that urology and even the medical science is advancing every day. And now the future probably lies in technology like robotics, nanotechnology that we discussed today. And today we are really fortunate to have with us a person who has been, we can call a living legend in urology. And I call it, just share the presentation. Yeah. And we cannot have a better person than him to grace this occasion of our teaching class on nanotechnology, because I think that he has been an academician par excellence. And I welcome Dr. Mahendra Bhandari. Sir, you are most welcome in our teaching class today. Thank you for gracing the occasion. And we all know, just make that full slide, please. We all know Sir has been, Sir, please take us, please. Sir has been really instrumental in developing urology in our country. He was also part of our SMS alumni to begin with when he started his career. And then he went to Pondicherry to start the Department of Urology in Pondicherry JIPMA. Then he went to SGPGI Lucknow, again started the department there. He started cadaveric transplants there. He became the director of SGPGI and then became the vice chancellor at KGMC Lucknow. And then he went to United States and became the CEO in Vatikoti Foundation, where I think his contribution to robotics systems throughout the world is immense. So he has been involved in the most challenging part of urology, the innovations and the research part. He has also been the founding editor of Indian Journal of Urology. So we are really proud to have Dr. Mahendra Bhandari with us. And he has been awarded the BC Rao Award in 1995 also. And we are really grateful to him to have come here. And I would invite Dr. Mahendra Bhandari to kindly address our residents and faculty. Thanks.
Shivam, thanks for inviting and putting me down the memory lane. None of you would remember the times, and I had to live to really recognize where is Vivekanand Mark and where is the hospital road. Please, sir. It's homecoming for me. Most of you would you would not know that I was a student of SMS Medical College. Did my graduation in 69 and did masters in surgery in 72. It would have been 71 because of the war, the exam, January of 72. From here, Dr. Gangwal was instrumental in sending me to CMC Vellore. In those days, no need, nothing. It was credibility of not many departments. All India Institute, PGI, Medical College in Chennai, Madras, and CMC Vellore, which was a premier institution. It's good for you to know how times have grown. And Dr. Bhatt's only criteria was to train urologists in the states where there were no qualified urologists. Dr. Mathur, who was my mentor, was my senior at CMC Vellore. And Dr. H.K. Das Gupta, Dr. H.K. Das Gupta was decidedly the first qualified MCH urology from CMC, the PGI Chandigarh. And two of us were from Vellore. Dr. Bhatt was very particular that we go back to the state. So there was no job in here, Dr. Gangwal, and I managed to get Pools officer's position here. After that, about, I think, 8 or 9 months after, there was a Public Service Commission interview for the post of lecturer in surgery. I remember it very well that this post had come after several years, 3 positions, 27 applicants. And 24 of them my teachers, including Dr. Balchandra Agarwal, Balchand Sharma, who taught us in emergency and all. And I said, let's go. Important to know the history of urology in this place. And I got a reply from the Public Service Commission 2 days before interview that you are not qualified for this position. Requirement was 2 years of after MS And this position was, horses were running. I just thought I'll try what I can do. Dr. Mathur by then had gone to Ajmer as a reader on promotion. Dr. Gangwal had nobody, so I worked as pool officer. Dr. Kalla was there, but at that time we had inherited our surgical unit. Dr. Kalla was my registrar. So I said, took a bus from here for public to Ajmer, entered, and watchman would not let me enter. Any appointment? I said no. I said, what to do? First experience of secretariat will sail through some patient and all, but in the meantime, one gentleman was walking with a file. I thought he's an officer. I said, could I talk to him? He said, I don't know who he is. So Chaukidar thought that, so he let me go in. I had an access and I talked to this man. He was administrative officer. And incidentally, he knew about my case. So I said, I want to see Mr. Kapoor. Mr. Kapoor was, if you know, was Oxford guy and no nonsense, So he said, don't even talk of meeting Dr. Kapoor. You don't have an appointment, and he's very, very strict about this. So why don't you come to me? Can I help you? Very nice man. He talked to me and he said, हाँ डॉक्टर साहब ऐसा था कि वो आपका एक्सपीरियंस था वो यूरोलॉजी में था तो सर्जरी में नहीं गिनते मानते हम तो मैंने उनसे कहा मैं तो एमसीएच मेरी एडिशनल क्वालिफिकेशन है नहीं मानते तो मैं काट देता हूँ तो सर्जरी की पोजीशन है उन्होंने कहा नहीं डॉक्टर साहब ऐसे नहीं हो सकता है और आप पढ़ कैसे सकते हो उस टाइम या तो आप पढ़ो या पढ़ाओ टीचिंग एक्सपीरियंस चाहिए मैंने कहा यार ये बताओ कि आप पढ़े बिना कैसे पढ़ाए खैर उन्होंने 5 मिनट उसने कहा कैसा लगता है कि आप चेयरमैन साहब को कन्विंस कर सकते हैं मेरा नाम मत लीजिए और ऊपर चले जाइए तो वहां से एक्सेस मिल गई ऊपर आए तो मिस्टर कपूर वॉज वॉकिंग आउट यू कैन सी चुरुट मुंह में यू कैन मेक आउट ग्रैंड पर्सनैलिटी मैं यूं खड़ा हो गया यस यंग मैन हाउ कैन आई हेल्प यू यू लुकिंग फॉर समथिंग आई सेड आई एम लुकिंग फॉर यू यू हैव एन अपॉइंटमेंट नो आई सेड नो आई हैव टू गो टू हॉस्पिटल get my cardiac checkup. I said, I'm not here to withhold you from going, but no, you have to have appointment to see me. Then give me the appointment. So then he understood, what is the problem? Can you briefly tell me? I said, your Public Service Commission says that I am not eligible, and you say that, and I say that I'm overqualified. So I have an additional qualification. So he said that, look, I'll do one thing. Chapadasi को बुलाया उन्होंने आप इनको याकूब साहब के पास ले जाएं. He is a member. उनके member से बात करके मैं decision लूंगा. Tomorrow 7 o'clock. Then I told him that day after tomorrow is the interview. He said no emotionalism. Either they would be interview with you, or we'll convince you. So go to याकूब साहब. तो हम चेयरमैन साहब के आदमी हो गए. याकूब साहब के पास ले गया वो हाँ आई डॉक्टर साहब चाय वाय लाई क्या हो गया चेयरमैन साहब कैसे भेजा भाई तो मैंने कहा सर ऐसी बात है तो उनको 1 घंटे में मेरे को समझाना पड़ा एमबीबीएस क्या होती है एमएस क्या होती है एमसीएच क्या होती है डॉक्टर साहब बात तो आपकी ठीक लग रही है अब ये उनकी भी सुन लें क्यों उन्होंने ऐसा किया तो खैर आप जाइए सुबह आपको 7 बजे बुलाया है नीचे आके मैंने कहा भैया तू अपॉइंटमेंट है हमारा 7 बजे बाद मत रोकना 7 बजे में बराबर 5 मिनट नीचे पहुंचा 7 बजे चेयरमैन डिड नॉट कम आउट वही एडमिनिस्ट्रेटिव ऑफिसर फाइल लेके निकला बाहर उनके कमरे से क्या ये डॉक्टर साहब आपको कॉल एंड देन इट वाज अ हिस्ट्री सो दैट वाज द बिगिनिंग ऑफ यूरोलॉजी एट दिस. And with what excitement and hard work Dr. Gangwal created the Urology Research Center. Always we would be enviable of Dr. Sethi's PMRC block. And I was occupant of the office, which was a neurourology lab. It was one of the earliest stone center. उसके बाद में था, उसके पहले थी. I worked here for 11 months and then went to this. Now, this is, I wanted to give a background, and then I have always been in touch with department. I have no formal lecture prepared for today. This kindness of Shivam, so I said we'll interact with you. So I would begin if you have any questions, anything particularly you want me to address. Anything, feel free.
For the residents after MCH now, we have so many super specialties coming up. What is the way forward? This because we don't have like any formal super specialty training to offer, for example, like a 1-year PDCC or a 2-year PDCC. So I see that in the near future, there will be so much of emphasis on subspecializations after neurology. So what is your take on that?
We are talking of skill set. I'll talk very basic. What makes a doctor? And those things will be answered. You know, I didn't plan to become a urologist. I didn't know much because I worked with Dr. Gangwal and he had a bias in urology. And that urology was mainly stones and prostates, transverse cycle prostate. So to answer this question, I'll go back to my experience and I'll talk of 3 patients, which would put the whole perspective of why you guys are doing urology or why you are a doctor. And these 3 patients have taught me the maximum lessons in my life. I'll top up the name. One patient I had operated when I was at All India Institute in 1976. 2.5-year-old child referred from BHU to Institute. 104.5 fever since childhood. Pouring out pus from one badly done ureterostomy. It was like intestine here. And talked to the mother, and he said that out of 2.5 years since the child was born, 1.5 years we have spent in the hospital. How trajectory of development changes you learn from this example. In those days, first thing I did was revise this into a good ureterostomy. And I used to do sober and white. So took the redundant part here and joined the thing on both the sides. Child improved, fever we could control, very limited choice of antibiotics. We were scared of giving kanamycin. Thereafter, in those days, it was an aggressive surgery era for pediatric, and second patient also would fit into that. We were all influenced by Hardy-Hendren's total corrections. Till the great Ormond Street came with the conservative treatment for megaureters or whatever you call. So I think it took me about 1.5 years to complete this child. I think 6 procedures I did. Finally, we closed this, both the ureterostomies. Everything was fine. We did an IVP, and both sides were reimplanted with good tunnels. So there was no reflux. And the intestines, like ureter, was absolutely normal, except for kings. After 1 year or so, I went to Pondicherry, and these parents were in touch with me postally, but nothing. Till I was in India, and father was working in Allahabad in fertilizer IFCO. So they will visit me, and I see the boy was in engineering, and all. I started talking to him. This was in 90s. And only thing he remembered was that my mother used to say that I was very sick when I was a child. these scars, very fine scars, 4 scars, 1 bladder scar. Thereafter, I lost contact. In 2006, when I went to United States, in 2006 itself, there was a message to my secretary, someone like his name, that his father is trying to contact you. And then there was a phone call from America, from Texas. He said, I am so-and-so, you remember me? So he is, since then I'm following, so till 16 years I'm there. He is close to 52 years. Why he called me and searched me out? Because his creatinine started jumping a little, 1.3 or something. Very carefully listen how many lessons are written in this. And his nephrologist, as usual, got the CT scan and there was found a holdup and said that your kidney ureter is blocked and we'll have to fix it up, refer to the urologist. This boy he wouldn't do anything until he talks to me. He talked to me and that is the overconfidence. I told on phone that, look, I don't believe in that because I knew that ultimately this kidney is some way or the other, it is going to get into end-stage disease. I said, this ureter has no business to narrow after 32 years. I don't believe that. And did you show him the old x-rays to compare or not? So lesson 1, that we pass judgment on corridors without longitudinally looking at the patient. Many times what you see, radiologists usually would report something. So the improvement, as you know, I don't have to tell, is relative in terms of what you have got with you. You can't rewrite the story. Anyway, I said, you come over, he came there. I was not practicing at that time. So Jack Elder was there and I told Jack, I don't want to get biased. This is what it is. And Jack told that let's put a perk and do a Whittaker. We used to do a lot. And with a contrast study, contrast flows down. What it was the additions, retroperitoneizing or whatever it is. Lesson 1, none of you would agree with the kind of treatment I did at that time. You will do McGovern for the upper ureter and lower ureter, and it's much more standard and simple. Now, what matters here? In conferences, we keep on blowing our lungs out on the latest technique and 50 cases. So the biggest lesson is not the technique, not the surgeon. What matters is the patient outcome. I can give you a number of examples. I had 140 cases of Marshall Machete by the time I was in Pondicherry. At that time, needle suspension had come. And everybody was started. This is the old technique. So we started to be much simpler than doing a Marshall Machete. We started doing this, and I happened to meet Stemi also in Florida. And so we had a patient, a very VIP patient from Bangalore, had a needle suspension done and still recurrence. So what would you do? Second needle suspension? Maybe I had a bias. I said, no, I'll do open. And what I find there is the bladder has been lifted up and ureter is kinked like serpent. So it is not the technique, it is how you do it and what's your understanding of the procedure. And ultimately, we cured the lady for a period I followed by the old procedure. So there is nothing new and nothing no, The question is remote. If you are asked what is the latest technique to do a hypospedia, it doesn't work in our specialty. I remember one of my very dear friend was failed by an examiner. on CMC Vellore. They asked him a case of hypospadias. So what would you do? So he mentioned some technique by Shafiq or something which had come in paper. So he said that I will do Shafiq's procedure. 3 questions and no more questions. Said, have you done one? No. Have you seen one? No. Thank you very much. Dr. Bhatt's one of the most favorite students. And Dr. Bhatt always wielded an influence on examiners, and they had tremendous understanding. So Dr. Bhatt said, no, something, probably these guys read a lot of latest things and all, but he said, HS, tell me one thing. If your son has a hypospadias, would you like a surgeon to do a procedure who has not seen one, not done one? So there is nothing in the mind of examiners to ask you. Be honest to yourself. If you have not done it, not done it. You know, these specialties refer one to other. I'll use some of it of my next patient. Next patient in 1989 and 19-year-old boy, 19-day-old boy, brought from Allahabad. Very. You can make out the very rich people, about 30, 40 people, and phone calls and all. And this boy came and we did a study and we found a valve. And I always been working in urethra and strictures. I hated to enter anything through urethra. So in those days, I was very fond of doing transverse cycle antegrade bone. And I never believed that valve should be damaged, because most of the after effect of the valve surgery is because you try to be overdoing that. And I had done about 15 cases in Pondicherry where there was no diathermy for me. So all I would do is take that hook, break the configuration and put the catheter. So there are no flaps, they'll get adhered. So wall needed a very minimum thing. And this to do in a 19 days old per urethra, even if you have smaller scope. So I did that, put a implant sheet and did the valve. That's all I did. Child gained weight, no infections, emptying bladder, everything was fine. After we were following very regularly, we found that child had unstable bladder. And one side was 10% EGFR, and other was kidney was good. Bladder was, we did a urodynamic. Now, this is another lesson. We did a urodynamic because we wanted to see whether we augment the bladder or not. And child had a mortal septicemia in the hospital. Another lesson. Whenever you invasive investigation in a patient where immune complexes are compromised, think of one odd patient who had gone, because people have lost these patients. Anyway, because we were in the ICU, we kept him in 2 days and bring him out of septicemia. Now, every investigation is to viewed before you do it in terms of what information would be valuable, is a trade-off. It's not that I'll do series by one, or whether pressure flow study was needed or not, may not be. And then what we did was, we did laparoscopically, did a laparoscopic nephrectomy, and took that ureter and augmented the bladder. It was big ureter. And all his bladder symptoms settled, and maybe he was still at 3 or 4. I think 3 years ago, I get a call from Oxford. And he said, "Uncle, I am Meeta's son. You know me?" I said, Dhruv, what are you doing? Okay, I am registered for my PhD and I'll be in Canada. And my mother said I should get in touch with him. His renal functions are normal. He settled in Canada. Now, I'm not telling that we did great things, but all I'm trying to say, there are two components of the profession we practice. We are focused on surgical skills, instruments, and gadgets. This is the part we do, but the response of the human medicine comes from the human component of the patient. None of them know what we did in the four walls of operating rooms. How does it matter to them? A patient comes to you with a very simple problem of tremors, and we complicate it by telling you have thyrotoxicosis. He comes with a simple contract. What you do, I don't know. I have this problem, solve it. Same thing in urology. And we make jalebi out of it by telling in our own word that, oh, this will hypothetically doing. And we are very good at explaining things. It drained because there must be an edema there. Nobody has gone and documented edema or something. So the point I want to tell you that the entire profession of surgery, surgeons more, because physicians are less vulnerable. The surgeons put prostate, but the soundboard is the human side. Soundboard is the human side. No kidney has ever told you, whispered in your ear that I want to be progressive. I have some expectations from life. When you touch these kidneys, they're like any mortal, you know. So always, why I'm telling there is anguish? Because of technology, and I work at the cutting edge technology. You're talking about nano. I work for private funding, you know, angel investors, and I advise them on technology. And nanotechnology is doing wonders. And if you see the process of how nano particles are made, which to be used, or nano rods are made, it is exciting. But ultimate soundboard is what it does to the patient in terms of durable outcomes. So any technique you do, we have been in that, you know, it was very painful when people moved from laparoscopy to robotics, because whole excitement of laparoscopy went away. There was very little component of surgeon doing it. You asked to Indigill, you know, it's so exciting to do something, action. Surgeon needs action. But ultimately what matters is how it is perceived at the end of patient. Have you been able to improve the outcome, not therapeutically, on an evidence-based medicine? And that is research. I had must have trained about 100 postgraduates in Sanjay Gandhi itself, and many of them would be very clear at that level, sir, this all paper business and research is bunkum. We have already got plans to make a hospital, and so is investing in it. And I'll tell them, don't have to write papers, but learn one thing. At least learn to audit what you do before you do on the next patient. So research or high-end publications are not the beginning point. It is your responsibility towards the patient so that you gain more confidence to repeat the same procedure for the patient when you do next time. And there is a saying, pig doesn't top a pig. Every human being phenotype is different. You can't use generic experiences to say that I did in that, so it will work in this. every treatment needs to be tailored. So far the message I gave you was that there is nothing latest as far as I am concerned. I put them as one of the options, including robotics. And even robotics say that gallbladder or simple hydronephrotic kidney is overkill using robotic surgery. So they are all given you different options in your armamentarium. Responsibility is yours. Similarly, everything you take, hypospadias, so many surgeries are there. And I pick up bone with Sanjay only on one thing, that you guys and Babagli have projected it as a panacea, which I don't agree. If I show you 34 years follow-up of a island flap with blood supply from prepuce, what you have against the skin? So it is not, don't throw away anything from your armamentarium. And never criticize something without being expert on both the things. You can't compare. Criticism comes from open surgeons for laparoscopy, or we see in the era, Shivam also would remember, from open prostatectomy to transurethral. Mostly it would come from the transurethral people who don't know transurethral. Same thing is happening in robotic surgery. So you may have your opinion for that time, but wait till you develop proficiency. Surgery is what you choose right for the patient. And that's what I say. My endeavor to train resident was, they know more than me, or they knew more than me at that point in time in terms of techniques. And they'll tell me, sir, why don't you do this way? Because they watch the thing. My endeavor was that don't be swayed away by technology. Don't be swayed away by eloquent people coming and selling you idea about it. You need to translate into, and when I was here, there was a seminar like this, and Patricia Vickers told me to prepare on, in those days, Nachiket, the main thing was 3 things. The open prostatectomy, Freyers or Millins, or Freyers with reconstruction of the blood neck. So I read an article from Whittle Martin, was a surgeon, general surgeon turned urologist. And he said, to choose a prostatectomy for me depends upon 3 things. Size of the prostate, size of the patient, and size of the surgeon. So I emphasize here that you are sitting in the center and the patient knows you. You have to weigh in terms of what is needed for that patient, not what you would like to do. And 2, what is needed for that patient, which is within the limits of your proficiency. The last patient I'll tell you is still interesting. All I'm trying to tell you that you may do a simple urology procedure, but you are turning the whole family for the rest of the life, your advisor, whether you are physically present or not. Honored, sir.
Happy to see you after such a long time.
I'll vacate. I'll listen to you.
No.
Everything is great. I told Shivam, but I didn't know that he transited.
That was a surprise.
Yeah.
So happy to see you. Please continue.
Sir, please. Right. So our class is going on Zoom. It's on YouTube also. Everything. So sir is just addressing our residents and faculty.
So then this third patient is the one, what I'm trying to say, you invest little and accrue more. Don't, there may be 6 specialists involved in managing a patient's condition. But could you be the one the patient would trust only, even if 5 others are very eminent specialists? And this story is like this. This was a 18-year-old girl, very beautiful girl from Kanpur. And she was brought, very simple thing, one-sided symptomatic pelvic junction obstruction. And those days we used to do endopilotomy. So myself and Rajesh did endopilotomy, and we saw that it didn't work. So we did a reconstructed, very simple, nothing. And the girl went home in 7 days and everything was fine. Again, she got married, children, 90 to 2022, June. I had no contact. And many times, my contacts are through Akshay. So Akshay called and said that somebody started talking to me that I had operated upon that girl for pyeloplasty and all. I thought it is you. So I have given your number to them and I'm telling you. So husband called me. I never met the husband. And he said, this girl refuses to listen to anybody. She wants to talk to you only before we take a decision. And we are in a very bad situation. She is, you can count 45 years, 3 grown-up big children, sons, very caring husband. So I said, how can I help you? Immediately you think and blame yourself, what the hell could happen after 25 years of pyeloplasty? He said no. Then to cut the story short, it was ovarian cancer with bumps, carcinoma peritoneal, and they were very well to do, so they took opinion from Tata and everywhere. They were to go for 6 cycles of chemotherapy. And girl said, no, I want to talk to him. So I talked to her and I said that let me give 2 days to understand the subject. I called my contacts as an oncologist there and surgeon in this place, and we agreed, and I convinced that you have 6 cycles of chemotherapy. I was inside very pained because what a girl and what could happen. And this disease looked to be florid. And so they gave cycles, no response. No response. So chemotherapists, oncologists would never give up. So they designed another protocol. And so I said, no, hold on. Now I have a prerogative. So I got at 3-4 places, whole genomic profile, and these drugs were useless according to that profile. We got the biopsy done. None of them agreed, but ultimately it turned out to be epithelial carcinoma, low-grade epithelial carcinoma. Now, low-grade epithelial carcinoma, if you know, is a silver lining in ovarian cancer. It is 5% patients, and it has the best outcome, and nothing works on it except for surgery. So we found a surgeon, and they prepared for even frozen sections, and they said we will put high pack if need be. And surgeon could make it into R0. No residual recurrence. Had a temporary ileostomy, which was closed. And to cut the story short, she's fine. I don't know, it's still to be seen. The point I want to make is, I was a bad messenger to what oncologists said, and this, all anxious moments, I had to really deal with it. But the pleasure of that pyeloplasty, throwing the whole patient and the family in my lap, which I could have easily declined by my arrogance. I could have said simple, I have nothing to do with it. I am a urologist, your pelvis, my surgery is fine, you go anywhere. So the lesson here is, I'm not trying to tell you, most of you would be already doing, but these are my own lessons. Always treat the patient as a whole. besides your focus on condition you have, a patient might have, there is a psyche, there is emotion, there is a whole lot of relationship, and they are in the most difficult times of their life in terms of physical, mental, psychological, economical, social stress. And you are the only one. So I always think that if I could have lowered my giving and taking status to be with the patient, it would give much more satisfaction to him. And then we have our own compulsions. Patient may be over demanding. It's okay, it doesn't matter. But you have to put yourself in the shoes of the patient. A patiently answered question, you may not have an explanation, maybe just enough as a treatment. I went for a spiritual camp in Raipur before coming here. And it was very intense, 8 days camp. And one person was disturbing us so much. Everywhere, 5 minutes, he asks an irrelevant question and gives, I want to tell you 2 stories. So our teacher was very patient, He heard him, somehow they said, note it down, we'll answer this question, you can meet me outside. But it was getting on nerves of everybody, this guy. And he was in the evening group discussion also with me. And he wouldn't let group go. We decide any protocol and he has so much to say. So everybody said, why waste time? They left the group. 3 of us left. So I said to this man, I'm observing you since yesterday. You have so much to say. And nobody wants to listen to you. I want to listen to you. So if they are not listening, they are losers. I said, yes, I want to listen to you. I heard him patiently next day on breakfast for 45 or 40 minutes. And he was obviously disturbed by how his brother devastated him of his property, father's property, and he had a lot of pains and all. So I said, you have so interesting stories, so much of lessons to be learned. Only thing, last sentence I said, speak to the people who want to listen to you. People have no time to listen to you. I said, I realized this. Next day, he didn't give up his habit of asking, but then he'll directly not go. He said close to me, can you ask them that I want to speak? And then I said, no, I'll tell you when there is a time to speak. So human psyche is so interesting, and nobody would know more than Dr. Sudhir Bhandari. And that's why I have got senile. I don't choose doctors